Hi, I'm Dr. David Hornbrook. I'm just having this crazy candid conversation with Dr. Mark Montgomery, and we've been friends for 20 years almost, and we're going to do a podcast in a little bit, but we had this crazy phone conversation about what direction I wanted to go with that, and now we're kind of brainstorming, and I'm going to ask him some questions that I asked him 20 years ago that I'm still thinking about, and I think a lot of us are thinking about. So, you know, Mark, one of the early things you taught me, because I was a quote-unquote cosmetic dentist, which I wouldn't call myself that today, but and it's about things that are going on in the mouth that are causing our patients to maybe have ugly smiles or pain or breakage, and then that can transfer to, we do beautiful veneers and they fail again. And you know, you've always used the term destructive forces, and we see that all the time. I mean, every dentist saying, "Oh, I saw that," but we may really not know what it is or how to handle that. So, you know, we think about destructive forces. Well, first is, you know, patient opens their mouth, let's say a new exam or whatever. I mean, what is evidence of that? What is that?
Yeah. I mean, I totally agree. There's usually, when we see a patient, maybe for cosmetic reasons even, there's a reason that things don't look the way we think they should look or the way the patient wants them to look. And when we have an opportunity to help this patient improve their smile, we always have to look underneath and say, what are the things that are going wrong underneath here so that we can manage that as we create this gorgeous smile.
Right.
So, of course, I mean, a lot of the things that we see as evidence of problems are things that we, you know, normally look at, but it's real important for us to consider the evidence of destructive problems or ongoing dysfunction. And usually nowadays, when I'm talking to the patient, I'm just saying, what's the evidence that we have a force-related problem in your mouth?
Okay. And you know, it's one thing if I put in 10 veneers, I do a full mouth rehab and it fails or it's successful. But, you know, the other thing is a patient comes in, they're 45 years old, there's stuff going on, and even if we do know dentistry, and we do know restorative dentistry and know that there are things that I can start doing now so that 20 years down the road, we're looking at a picture that we can still restore or fix versus a destroyed dentition. So I want to talk about that.
So there's maintenance things that we might want to take care
Absolutely.
of in order to stabilize these problems. So what are some of the things that we see? I think, you know, probably the biggest thing that you and I see on a regular basis is wear on the front teeth.
And we see that all the time. And then we think, oh, we've got all these strong materials, whether it be zirconia or lithium disilicate. Let's just make them longer again, because that's how God did it, right?
I think in dentistry, over the years, we've tended to over-engineer in areas where we didn't understand the underlying problem.
Yeah,
so
agree.
If we do get control of the underlying problem, then we can use the most beautiful restorative materials and not necessarily have to over-engineer. So wear on the front teeth. I think another thing is we see recession and abfractions.
And those are occlusal as well as gingival.
Occlusal as well as gingival abfractions. Anything, you know, here that indicates that there's too much horizontal force on these teeth that's creating a bending or a breakdown of the enamel rods.
Okay.
In there. What are some of the other things that you see as evidence of problems when you look in someone's mouth?
I see destruction of existing restorations. PFMs on second molars with no porcelain on them.
Okay, so destruction of existing
Or natural dentition.
But I'm going to also include the fact that those restorations are on there is evidence that there was a problem at some point.
Right.
Most of the time, the reasons that we restore teeth is not just because of infection or acid erosion.
Right.
Most of the time we restore tooth, it's because there was too much force at some point. So even restored teeth or missing teeth,
or endodontically treated teeth on the same tooth on the two sides of the arch, close to the hinge axis. See that all the time.
Anything that we see where there's been too much force on the teeth. I think even in the front of the mouth we see dark front tooth. Now that might be like you always say, maybe it was a single traumatic event.
Right. We hope it is.
Because
That's easy to fix.
That's easier for us to fix. But when we see dark, non-vital teeth, sometimes that's evidence that there's too much force. Another thing I see quite a bit of, and I would imagine it's one of the things that we get concerned about most with ceramics, is when we see exostosis, especially on the upper arch, and we see evidence of clenching, like scalloped tongue.
Right.
So I'm just going to say exostosis. I'm going to put those in the same category: exostosis, scalloped tongue.
I would also add very definitive linea alba. We see that on these people that are clenching. It's kind of what I call a red flag that there's something going on that they're causing that callus on the side of their cheek.
Right. And a lot of what we found now is that a lot of the forces that generate clenching and these issues are directly related to two things. One is lingualized forces on the teeth. So when we have narrow arches, and we'll talk about this more in a minute, but narrow arches with horizontal forces triggers this clenching reflex. So narrow arches or a history of clenching, if the patient says, yeah, I'm clenching my teeth, that's evidence to us and that there's a problem here. So narrow arches, I would also say crowding in the front of the mouth is directly related to too much force. So crowding of anteriors, let me ask you this, does that crowding ever get better by itself?
No.
It usually gets
worse.
Which means if it's getting worse, the only way teeth move is by putting force on them. Right. So crowding of anteriors almost always indicates an ongoing problem of too much force.
Now, how about diastema and posterior? Now I'm trapping food between these molars.
So anything that changes the tooth position, I would say. So, you get diastemas in the back, you get flaring in the front teeth. Sometimes you can even get diastemas in the front as a result of too much force in the back and the patient's pushing forward. And, all of these things, I think are strong evidence that we have a sensory motor problem. I'm going to add a couple of quick things here. One of the things I think is a patient history of pain, headaches, snoring, apnea, stuff like that a lot of dentists have become really aware of,
right.
Dealing with these things. Generally speaking, these things may not be necessarily the direct result of a force problem, but these things get locked in by force problems. So we want to make sure that if we're going to be treating a patient, whether it be for pain or maintenance therapy or cosmetic dentistry or restorative care, I think that when we see this list, and how many patients have we seen where we see a lot of these in the same
right.
patient, I think that's a place where we need to take a step back and say, okay, if these are the things we're seeing, what are the main things that generate
right.
these issues?
Okay, so let's talk about that. So here we have all this evidence, and now we have to kind of come up with a treatment plan. Let's talk about the causes first. So
Causes or concerns, plan. Or, I don't want to get in the weeds on this, but there are certain things that I would say, are the most destructive problems in a patient's dentition.
Okay, so let's kind of list them in a semi-order.
Okay, so I think that if I was going to say what my number one cause or concern is, it's the thing that causes the crowding. That causes the clenching and the high forces, and so that's going to be lingualized forces on a narrow arch. Too often, I think we don't realize that the reason that patients have these this tendency to clench down is because they've got occlusal contacts on the facial surface of their
and
lower teeth.
that's where the molars are going like this, on lingually inclined.
They're leaned
and the cusp tip
in.
cannot go into the fossa.
Right.
Opposing.
And it triggers that. It triggers a real sensory motor reflex that makes the patient close down and clench down. That ends up resulting in certainly some of these changes of tooth position, the clenching, these exostosis, scalloped tongue. It can cause teeth to break, and it can certainly be responsible for a lot of our abfractions and recession and things like that. Mm-hmm. So
and us as dentists, I mean, we sometimes, this is iatrogenic because we put a crown in that we don't have a sharp cusp into a fossa. We kind of make it this big broad thing, and we have a contact on the, again, facial or mandibular molars I see all the time.
Right. And, I think that's because, once again, we're really good at reducing the occlusal surfaces. We're not real good at depth cutting the areas that really need to be depth cut. I'm going to add the word horizontal in here because I think horizontal forces are very destructive to a patient's
horizontal in the posterior or everywhere?
Everywhere,
okay.
Really, yeah. So these lingualized forces on narrow arches, essentially what this is a problem with what I call posterior envelope of function. How can we chew normally if these teeth are rolled in and if the upper teeth are too narrow, the upper arch is narrow, the mandible has to be able to fit inside that, and that creates a problem with the forces.
So, sorry, when you see that, are you seeing more lateral chewers then with these patients?
No, I see patients who have evidence of almost being trapped posteriorly, and the way they get away from this is by trying to move their jaw forward, but they're kind of locked in.
Okay.
And so that ends up perpetuating the clenching. So posterior envelope of function issue. The second thing here I'm going to say is anterior envelope of function. Restricted. Anterior restricted chewing. And there's been a lot of work done in this area. A lot of people focus heavily on this. If we're going to summarize this, it's just a deep, tight overbite. Deep, tight overbite. So I think about this like these are narrow, this is deep and tight. Those are big, destructive problems for our patients. So the way we measure this is usually by measuring the ratio of how much overbite there is to how much overjet there is. So and we do it the other way. So overjet divided by overbite should be between 50 and 70%. Okay. So that's a simple measurement that dentists can make and can look at these patients. If you've got 1 millimeter of overjet and 4 millimeters of overbite, that's only 25% ratio. Mm-hmm. That's too tight. But if you have 2 millimeters of overjet and 3 millimeters of overbite, that's 67%. That fits in our range. Okay. So then it gives us an idea of whether this is restricted.
So if they're restricted, are they banging on teeth during chewing? And I mean, what is typically, are they clenching into that? Because they're hitting on their facial surfaces typically.
The best way for me to say it is when you're chewing with an anterior restricted envelope, it's hard to get the mandible to fit underneath those front teeth. So a lot of things happen as a result of that. It can distalize the jaw. It can create muscle tension problems.
It can break front teeth.
It can break front teeth. It can wear the lingual of the upper front teeth. It can certainly wear the incisal edges of the lower front teeth.
Or we get more crowding in the anteriors.
We get enhanced crowding, and sometimes we end up, as a result, we'll get pain on some of these patients. So an anterior restricted envelope of function is a really big deal for us.
Okay.
The thing that goes along with these two is class 2 canines. When I see class 2 canines, I know that when that patient's chewing on a bolus of food, when they're going through the final crush on that bolus of food, the tendency is for that mandible to be distalized instead of supported in its normal position. Okay. And so class 2 canines are a chewing problem. Yes, class 2s have more overjet, they don't look as good. There are aesthetic reasons that we don't like class 2s, but class 2 canines are a real functional problem for patients who have a tendency to have, especially if this is combined with an anterior restricted, like a class 2 division 2 case, then those patients are often very susceptible to inflammation in the joints, distalized condyles, dislocated condyles. It's just not a stable chewing place.
Okay.
We'd much rather see class 1 canines for a stabilized chewing situation.
All right.
So, so these are big picture items that really contribute to this evidence over here. These are the things that cause this. And then I'm going to add the two things that we most commonly think about, and that's the occlusal forces and I'm just going to say when it's out of balance. So if there's imbalance, if there's imbalance left to right, if it hits early on the front and later on the back, or if it hits early in the back and later in the front, any kind of unbalanced forces in this chewing system is going to feed back to abnormal forces. Right. Let me give you an example of that, and this is something that you and I have worked with for many years. And that's like if we have a mesioangular second molar, and the distal facial cusp is sticking up in the air off of the occlusal plane, right, then the patient's going to have to avoid that. Right. And the only way they can avoid that is to move their mandible forward to chew, and now we see wear on front teeth and canines. Mm-hmm. And when we see that, that's this force imbalance, and there are a lot of contributors to this. It could be an occlusal plane issue, any kind of malocclusion, right, I guess, could create this.
And then we go in and try to restore it, and we break our porcelain.
Right. If we don't control the imbalance in the system, then that stress is going to show back up again later. Right. And so, I mean, I had that one patient where they had root canal after root canal after root canal on the front teeth, and they never looked in the back to see where the imbalance was that was overloading those front teeth, right, all the time.
Yeah, I think that whole avoidance is something that, I mean, they don't talk about it in dental school, and you don't really think about it all the time, but a lot of failures is, you're right, overloading because they're avoiding something else and they're hitting on something else.
Avoidance patterns.
Yeah.
Yeah. And then the next aspect of this is the occlusal forces in chewing. So I'm going to call it chewing forces. And the way we think about this most often is working interferences and balancing interferences. So we'll just say working and balancing interferences.
So let's talk a little bit about that, because, one of the things we do at Keating is, inherently our ceramists try to build in, canine guidance or anterior guidance to eliminate those working and balancing interferences. What kind of problems are we going to see? So we have all of a sudden we have a molar that comes into play as I go laterally. Or as I go to lateral to the right, all of a sudden my left mesiolingual cusp on tooth number 15 is hitting as I'm going lateral. What's the big deal with that?
Well, the big deal is, once again, it's this avoidance problem. And anytime you're trying to chew on the right and the left side's getting in the way, then your brain has to figure out another way to chew through that bolus of food. And so it's not so much just us. I mean, we as dentists, we think like articulators, like
right.
when the patient slides to the left, that we engage this balancing interference. The problem is when they're trying to chew on the left and the right side's getting in the way. In other words, we do have a balancing interference. What does that do to the chewing function?
Okay.
And these interferences always trigger a repositioning of the jaw forward.
Okay.
Always. And which means, and the muscles that do that, I know you don't want to get too far into that, but the muscles that do that are your lateral pterygoids,
right.
and they're the ones that are always hot and tender and on fire. And lateral pterygoids are mostly opening muscles.
All right.
But we're making them active during closing. So it's like you've got your biceps and triceps working at the same time, and so you're always fighting. And when this patient is fighting their own system with trying to avoid these working and balancing interferences, then we see wear, recession, destruction of teeth. We see all of these dysfunctional problems, and we see pain showing up. So this working and non-working interferences is a big deal. And over the years we've talked about it like, we need immediate canine guidance. Mm-hmm. The problem is a lot of people say, look, I've got canine guidance, and they slide their jaw way over here.
Right.
And you can see the canines touching, but that's not where the issue is. It's very close to closed, mm-hmm. and it's what we would call immediate canine guidance, or a short disclusion time.
Right.
There's a for people that use T-scan out there, there's a term that's called disclusion time reduction. In other words, we want the most immediate guidance to closure possible. Right. And that's what takes care of these interferences. That's what controls a lot of this abnormal positioning of the jaw during chewing. So whether it's imbalance left-right or unbalanced around the arch, we'll see patients who'll do a scan on them, and they'll have like 35% of the force just on
a
second
single
molars.
tooth. Yeah.
When you have 35% of the force on second molars on the right, I'll almost guarantee you, I would go to the track on this one, that you're going to have wear on the contralateral canines. Right. So this imbalance and avoidance pattern is big, and certainly the working and balancing interferences create the same avoidance pattern that we see here. So these are my causes. So now the question is, how do I look at a patient to see whether or not we can control these concerns? And I would just say that when I'm doing my smile design and my functional design, which you and I do simultaneously, that these are the things that we have to control. These are the main things that we need to control. Can we get class 1 canine function? If we can, awesome. Do we need to broaden the arches? Mm-hmm. And can we do that restoratively? Sometimes, yes, we can just restore those posteriors more upright. Right. Sometimes it's so severe and you've restricted your tongue space and all of that, that maybe orthodontics is a good option. Right. So, to think about, these are the things we want to control. It's easy for us to figure out how to control something if we know what it is we're trying to control.
Right.
And why we want to control it. The reason we want to control these things is so that our ceramics don't break, so that the patient doesn't have ongoing problems with pain or destruction. And unfortunately, the evidence for these issues sometimes just shows up as one broken tooth. Mm-hmm. We have one broken tooth, and for me, that's the time I want to try to get control of it, is when I first see it.
Yeah, that makes a lot of sense.
It's
so let's erase this.
Okay.
And So let's talk about what you would see as ideal. So let's say as you're talking to the orthodontist, so there's natural dentition, or you're talking to your ceramist as they design the ceramics or the wax up. What are some of the hard and fast rules that you're going to ask for, or that you would expect, or that you would desire?
Okay. So
That's a good job. It's better than I do.
as we go to, so what you're asking is, when we go in to design a patient's future for them.
Exactly.
So,
And it's not always restorative. You know, obviously I have patients in my practice that as much as they need a full mouth rehab, you know, $50,000 worth of dentistry is not an option for them.
right.
$20,000 may not be an option. But if I can slow things down, or if I do design some restorative care, how can I design it to maximize long-term prognosis?
Okay. So, and that design may not even be in an adult dentition in their 40s and 50s. Maybe it's in our kids.
Right.
You know, what are we looking for to really see how this is going to
Right.
be best? And all of these principles should hold all the way through.
Right.
Would you agree?
Absolutely. And I think that's a huge one, and something I learned from you a long time ago is it's no longer acceptable to send a prescription to the orthodontist. Here's little Jimmy, treat him.
Do it.
Right? Because, I mean, we see, and we can all relate to this, we've seen some crazy screwed up cases from the orthodontist.
Okay.
Because we didn't specify in a prescription, to me it's like, that's a prescription, what we wanted the final result to be. So I think that in itself is a learning experience as you sit down with the orthodontist. Listen, yeah, we want him to have a great smile. Yeah, we want Jimmy to look great for his senior pictures, but these are things so that when they're 35 or 50 or 70, that we can have less destruction.
So, as I think about design, you and I both have come to a pretty strong position on this, that our very first thing that we're going to look at is our smile.
Right.
And so I'm going to, in the interest of time here, I think I'm just going to say smile design. And in that, we have several things that are critical in our initial smile design. And I don't care if this is a growing kid or a patient who's in orthodontics. I need to design the elements that we know to be beautiful and natural and normal. So
Right.
the first thing here that we always look at is upper central incisor, incisal edge position, smile line. The same
Yeah.
things we would look at
Absolutely.
on dentures.
Profile,
Profile.
buccal quarter, which goes back to the whole lack of this lingualized, and you know, that was a huge problem with all the extractions that orthodontists used to do. I mean, inevitably everything the arch narrows,
So
and we get lingualized dentition.
I'm going to call that arch form. Buccal corridor.
Cusp-fossa relationships, not so much smile design. We can get into that as we talk about tooth anatomy and cusp-fossa relationships. But yeah, and we could add midline and the incisal edge inclination.
So let's put that
part of
on
our
here.
smile line,
Smile
yeah.
line, we'll say midline. Inclination. Those kinds of things. So I think most of us have a good understanding of how we would design the front of the mouth. But this is if this is wrong, there's almost no way that your
Too
function.
many teeth.
Is that better?
Perfect.
Okay. If this smile design is wrong, then there's no way that
The anal in me.
your functional part is going to end up being as ideal as possible.
Right.
So the first thing we're going to look at is smile design. And I'm also going to say face. Facial design or skeletal issues. So in this facial design skeletal issues, we're going to look at things such as position of the maxilla, position of the mandible. So we're going to do, I'm just going to say skeletal classification. Class 1, class 1, 2, 3, that kind of skeletal issue. And how big is it? For me, if this is over 3 millimeters off, I'm not going to be able to cheat with dentistry. Right. I'm going to need help.
You say over 3 millimeters off in which?
In any direction, whether it's if I'm more than 3 millimeters class 2 or more than 3 millimeters class 3.
And that's in the molar or the canine, or are you looking at molar relationships?
I look mostly at canine relationships. So, if I have a 5 millimeter class 2 canine, it's pretty hard for me to cheat that with just dentistry.
Right.
I have to think about orthodontics or orthognathics or growth and development if it's a child. I really want to be within 3 millimeters if I can.
Okay.
When I'm working on this, but I need to at least talk to the orthodontist or the surgeon or whatever, whatever. We need to consider that. The next thing on facial design is vertical dimension. There are a lot of ways to measure vertical dimension. We measure CEJ to CEJ measurements.
Of central, maxillary central and mandibular.
Yeah, from here to here.
Exactly.
You can measure it on a Ceph with lateral face height. You can use rule of thirds like we did on dentures. Mm-hmm. But essentially what we want facial balance here. And there are other issues with vertical, but this is a consideration we have to have when we're designing this patient's case. If this is normal, if this looks normal, and this is within 3 millimeters, and this is looking good, then we can go down into what we call functional dental design. Does that flow?
Yeah, that's perfect.
Well for you?
Mm-hmm.
So in functional dental design, those things that I said I wanted to get control over,
right.
Those are the things that
uprighted posterior teeth.
So the first thing I want normal arch form. That helps us with buccal quarter up here. It helps us with airway, breathing, tongue space, all of those things that we would expect. It helps with tongue position during swallowing and ongoing support for the case. We want normal arch form. It also allows our mandible to be in a class 1 position. When you have a narrow upper, the mandible is often trapped back. So we want to get normal arch form. That's one of the first things I want to look at. The next thing we're going to look for is to create balance between our smile and our anterior envelope of function. In other words, if I need to lengthen a front tooth up here, is that going to create too much overbite for me? So I want to look at, do I have balance between my smile and my anterior envelope of function? Right. So this is where I'm going to look at my incisal edges and look at how much overbite and overjet do I want. So I'm just going to write overbite, overjet, and overbite here because I think that's really my main frame of reference for an anterior envelope of function. And we talked about just a minute ago, this should be 50 to 70%, approximately. Right. These are just guidelines.
Right.
Okay. once we get that anterior envelope of function correct, then that's going to set up a lot of issues with our dental vertical dimension. So, you know, but that's going to be controlled there. So the next thing I want to see is, can I get class 1 canines? In my design, that's one of the main I don't want you to have to erase this. Class 1 canines. If I can get class 1 canines, I've got normal arch form, class 1 canines, good anterior envelope of function. I want beautiful posterior tooth anatomy.
Yeah, sharp cuss, deep fossa.
So-
Teeth that work.
I'm just going to say normal cusps, fossa, anatomy. And a level occlusal plane. When you get normal tooth anatomy and you get some cusps that are uprighted and up where they need to be, if you don't have a level occlusal plane, you're going to bump into a lot of interferences. And so then the last thing I want is I want balanced forces. And after I get my balanced forces, or as part of the balanced forces, I also want to say I've got immediate canine guidance.
And protrusive guidance.
Yeah.
In other words, we want pure axial forces on posterior teeth.
Right. So, normal cuspus anatomy, axial forces. Force. So I mean, this is not a really tough list, I don't think. So let's say I was sitting down with an orthodontist, and I would say, you know, I've got a patient who has a slightly short vertical dimension of occlusion, and I want to bring my upper incisal edge down in the smile, and I want to increase the lower face height to be in harmony with that. I'm pretty close to a class 1 canine, so I would say please finish this case with normal arch form. I want 3 millimeters of overbite and 2 millimeters of overjet. I want class 1 canines. I want axial forces on my posterior teeth with a level occlusal plane. Is that something that is possible for you?
Right.
And the orthodontist is going to say yes, no, maybe, or he might say yes, but I'm going to have to do some posterior intrusions using TADs, or maybe it's better off to be an orthognathic case,
Or you've got to combine it with restorative. I get that on adult ortho where it's, you know, I can't because the patient doesn't have any points on their mandibular canines.
Right.
So we line everything up and then we put new points on the canines restoratively.
Exactly. So, but this is an easy list to think through when you're talking to yourself or your laboratory about your wax up.
Right.
These are the same things I want on a design for a wax up. You know, smile design, skeletal design, functional design. It's the exact same thing on an ortho case, a growing patient, a restorative case, whatever it might be. These are the same things. They're the same principles that flow throughout everything we do. If we do this, then we can control those destructive problems. We can control that tight posterior envelope of function that creates clenching. We can control some of the problems we see with airway and pain. We can control this anterior envelope of function so that the patient can be supported in a normal condylar position without inflammation, and we can control these avoidance patterns, the dysfunction that ends up resulting in destroyed front teeth, and certainly if we can control that before we put ceramics on, then we can be a lot more confident with our ceramics.
And I think that's important. And, you know, like we said, if we set this up ahead of time, or we anticipate as we design and finish this case, we want these things. Because we've all had cases that have failed, whether it be chip bonding or chip anterior crown or 10 veneers and 3 of them have chipped. So, you know, I really appreciate, you know, the time you spent on this. And, you know, this is an abbreviated version of functional aesthetics, but I think these are things that dentists need to think about as they look at natural dentition, as they look at young kids, as they look at a case that they're going to put a beautiful new smile on.
Yeah, I mean, it all starts with what we said at the beginning. What's the evidence that things are not going well?
Yeah.
If the evidence is there that things are going the wrong way, as you know, I'm a big fan of what I call ING problems. That we have a tendency to say, oh, your lower arch is crowded. It's not crowded. It's collapsing. It's an ING problem. You don't have recession, you have receding. You know, these things are ongoing issues, and I mean, at least with clenching, we call it clenching. You know, but
instead of you clenched.
Yeah, you clenched. We don't say you clenched. Well, you clenched. Well, so when we see these things, we see this evidence. If our mindset is that this evidence is evidence of an ongoing issue, then what are the things we need to look at to manage that? Maybe a lot of these things in your patient are already normal. So then you just check them off the list. Well, that's normal, that's normal, that's normal. Ooh, this is not normal. Then what's creating that? And is it something that's going to be an ongoing issue for that patient? If it is, then let's get control of it however we need to with this type of an approach.
Awesome. Well, good. For those that haven't spent much time with Mark, his background is awesome. And not only has he had unbelievable training and trained others, he was the director of functional aesthetics at Pac Live with me, and then the Hornbrook group, and now he's with Trudenta, which deals with pain management, which is very, very exciting, through a system that combines different modalities to truly get your patient out of pain. They can reach you if they wanted more information.
Yeah,
how do they reach you?
You can reach me at montgomerymethod.com or at my email address, which I'll just write up here. You can contact me anytime. Let's do this that way.
Can't even remember your own email address.
No, I can't. I was just
spell
going.
that correct.
I've got too many email addresses. So let's just say it's Mark at
MontgomeryMethod.com. Great.
Yeah.
Well, I hope you had as much fun as I did. It was fun just to, we sat down, we've done these things over the last, 20 years, just putting pieces together and creating systems. And I hope our viewers and listeners enjoy this as well. And if you have any questions, contact Mark. You can always contact me at Hornbrook at KeatingDentalArts.com. We have a brand new website we're very excited about at Keating Dental Arts. Be sure to check that out, www.KeatingDentalArts.com. We also have some videos, some with Mark and some that we've done on whiteboards as well as on patients at DentalUp, all one word, .xyz. If you're ever in the Southern California area near Disneyland or Newport Beach, come by and see our beautiful lab and see our teaching operatory. We'd love to see you.